Welcome back to End Time TV's On the Edge. I'm Dr. Jonas Moses. With me this hour, Dr. Janet Hayes and Dr. Joan Flanders. We are talking this hour about cardiology, special procedures, both in invasive and non-invasive cardiology and interventional cardiology. We were in the middle of taking a look at some slides, and I believe that, let's see, we have slide number 4. Is that right? Yes. Okay. And that is, looks like a CTA scan versus cardiac cath scan. So can you tell us a little bit about that, Dr. Hayes?
So, in contrast to the prior slide where it's a very pretty white, clean, open artery, this is a different person's right coronary artery. On the left is the coronary CTA, and you can see it's cut off the screen a little bit, but down the bottom where the yellow arrow is, what is that? That is a previously stented artery. That is a stent that you're seeing. And unfortunately, you can't see the red, or perhaps your viewers can see it, but where the red arrows are, there are some narrowings. And that is then compared with the actual diagnostic image from the cardiac cath lab, where we actually have inserted a catheter into the coronary artery and injected dye directly, and showing the corresponding blockages. So coronary CTA is really the first challenge to showing anatomy of the coronary arteries non-invasively as well as you can in the cath lab invasively. And it's kind of the latest, greatest technique. It's receiving a lot of attention now, and it is moving very quickly in terms of technology is getting better and better with this. And it probably will replace a fair amount of the diagnostic caths, but not all of them. I have to point out that they're both anatomic studies, and they don't really show the physiology. And sometimes something looks like a blockage, but when you go in and actually do the physiologic studies, for example, in the cath lab, you can measure certain things about flow reserve or do an intravascular ultrasound and say it may look bad on the screen, but really the actual flow is okay. Or if you do a nuclear scan, that physiologically the flow still is okay at stress levels. So you have to also think in your mind and compare what is the anatomy versus what is the physiology to the true impact to the patient.
Okay. Let's see, next slide. All right, there we go. And this is, my note is CTA contrast-enhanced RCA aneurysm. So who wants to pick on that?
Well, this is, you almost have to be certified to be able to interpret this. But
okay.
It basically shows very nicely that not only can you see blockages, but you can see dilation of the blood vessels. An aneurysm happens when the blood vessel wall is weakened in an area, and then just like if you laid a garden hose in the sun and a portion of the garden hose bulged out, a portion of the artery bulges out. That can cause problems for patients, and it can mimic heart attack symptoms. So a fair amount of time we will find an answer by getting the cardiac CTA that is not a blockage.
Mm-hmm. Okay. Let's see, I think now we're moving on to SPECT. So the next slide. Now this is a gestalt here. You're going to have to tell us what we're looking at.
So this is an example of what I was saying, the actual physiology. This is actually a radioisotope that is injected in the vein of a patient, right, and they lie under a camera. It's a non-invasive test, but is one of the few that actually show the uptake by the actual cellular function of the cardiac muscle cells. And the ones that are receiving enough blood flow will take it up, and then you compare it, the stress images to the rest images. So this is part of a very classic bread and butter cardiology stress test, the nuclear stress images.
Are we looking here at no, these are false color images based on heat, or what are we looking at?
Well, you can program into the computer however what percent uptake you want represented by what color.
Okay.
So this shows up well on screen, so it's often used. But this, for example, is showing 3 different isotopes, 3 different somewhat techniques, but the heart sliced different ways and showing what the different isotopes look like for those particular studies. And if you look at the top row, for example, it should be a complete upside down U.
All right.
And it's not, so that means that the left half of the heart, which is probably the septum, is not getting good blood flow at that physiologic state, whatever it is. I don't know if it's a rest image or a stress image. But classically, you would compare a stress picture to a rest picture, and that would tell you a lot of information, once again, about how physiologically significant that anatomic blockage was that you saw on some of these other studies.
Okay. And let's see. So now we're going to go to slide number 7, is SPECT versus CT.
This is an interesting fusing of the two techniques. And
Okay.
there are some cameras actually coming out now that you can get the SPECT images and then turn around and get the CAT scan image and fuse the two. And once again, it's a lot of computer manipulation, but it can also, and this can hone down to the coronary level as well and try and show where once again, the arrow on the left is pointing to decreased uptake. And they're showing the corresponding artery on the CT side, the yellow arteries corresponding to that particular branch of that artery. That's where the blockage is. It's not clear enough to show the actual blockage, because this, once again, is that volume rendered pretty view, but not the nuts and bolts that we like to look at higher magnification. But
Okay.
it does fuse the two.
All right, next slide, please. So now we're getting into echo here, is that correct?
Yes.
That's correct.
And this would, let's see, this is transthoracic echo. So what are we looking at here? We're looking at a section through the heart from the top, or?
This is the bread and butter
All right.
test for cardiologists. And this gives us so much information about the anatomy of the heart and the physiology of the valvular lesions. It doesn't say much to us about the coronary flow. You can infer it based on certain walls that move or don't move. And this is unfortunately a still image, but most times this is a moving image.
All
and
right.
you can see all walls of the heart contracting well. You can see how well the valves are moving. And you can then switch to Doppler imaging to tell you more about the physiology of the valves, whether they're working properly, whether they're stenotic, or whether they're leaking badly. And you can come up with all sorts of important measurements about pressures inside the heart and in the lung, too. And this is, I think, the most frequently used test that cardiologists use on a day-to-day basis.
Hands down. This is one of the more cheaper imaging modalities. And then because it exploits a lot of physics, and because the heart is a moving target, you can actually infer a lot.
Great. We're going to go to a commercial break. Hold that thought. Stay with us. You're watching In Time TV's On the Edge. I'm Dr. Jonas Moses. This hour we are talking about cardiology and special techniques and images, and we'll be right back.